Good evening, everyone. How are we all? We're good. We're good. Welcome to this very special evening. My name is Tim McCallum, and I am very honoured to be your Master of Ceremonies for this Health Matters lecture series and tonight's theme of changing lives of people with a spinal cord injury. Before we begin, I would like to acknowledge the Yagara people and the Turrbal people as the traditional custodians of Meanjin, the lands on which we meet, work and learn. We pay our respects to Yagara and Turrbal elders past, present and emerging. We also acknowledge the traditional owner associations, including the Durrumbal people, elders that are here with us today, and those that have passed, and representatives for the Aboriginal community and organisations, and the important role that they play in responding to the needs and visions of the Aboriginal community in Australia. I also welcome our guest speakers here tonight, Dr. Claire Panagata, Associate Professor Mark Rittenberg, Ms. Ellen Gillespie, and Associate Professor Sean Tweedy. Give them a round of applause for being here. Distinguished guests, friends, and colleagues. It's lovely to have you all here. Just a little bit of housekeeping before we get started. In the unlikely event of an emergency, please follow the instructions from the venue staff. And of course, please turn your phones to either off or silent. And finally, if you are using any social media handles tonight, those of you that might be tech savvy, if you're tweeting even about tonight's presentation, please use the hashtag UQHealthMatters. That would be great. We'll try and make it go viral. Why not? So I'm very delighted to welcome you here this evening. As I said, my name is Tim McCallum. Very honoured to have been asked to play the role of MC tonight. I wear quite a few different hats this evening. First and foremost, I am a representative of Spinal Life Australia as a peer support officer based in the Spinal Injuries Unit at the PA Hospital. I'm also co-researcher, adjunct researcher for the Singing Chords project that also runs out of the Spinal Injuries Unit at the PA Hospital. I am a consumer. I think that's probably the most important role I play this evening. I myself had a spinal cord injury 23 years ago on the 13th of February 1999. When I dived over a wave in a Perth beach and hit my head on a sandbar, breaking my neck, damaging my spinal cord and consequently resulting in my current condition, quadriplegia. So I have a fair bit of stake in what is said tonight, really. And my 23 years of lived experience as someone with a spinal cord injury, I have seen some wonderful advances in medicine, in practices. I've seen wonderful achievements of people with spinal cord injuries living their lives, fulfilling their dreams, following their goals. And so tonight, I feel like my role is representing us, the ones who live this life, this challenging life. At some times in our lives we have incredible highs and we feel like valued members of society and contributing members of society, but we still have a long way to go before disability rights, human rights, equality, inclusion, access becomes the norm. And I think nights like tonight, where we can discuss incredible topics when it comes to the treatment and the rehabilitation and recovery of those with spinal cord injuries, to give people who do suffer these conditions the absolute best chance to still be themselves. And so I'm really personally looking forward to what our wonderful four speakers have to share with you tonight. We are going to have a Q&A session at the end of the speakers, and it would be really great if some of you, we've got plenty of time, so maybe all of you think of a question. if we've got time, I'll try and filter it through. We've got some great networking time at the end as well, so if you don't feel comfortable asking any questions at the end, you can certainly approach anyone in the room afterwards, where there'll be drinks and canapes to be served as well. So that's it for me. And in fact, for those of you who know me, I feel like I'm a much better singer than I am speaker. So I'm going to leave it to the professionals in the room to get up here and do their presentations. So it gives me great pleasure to welcome to the microphone our first speaker tonight, Dr. Claire Panagata, who's a rehabilitation medicine physician who works in the Queensland Spinal Cord Injury Service. She provides specialist rehabilitation for people with spinal cord injury in Queensland across the life continuum. In her non-clinical role, she's working to improve equity and access to health services for people with spinal cord injury in Queensland. Through her involvement with the Royal Australasian College of Physicians, she coordinates assessments for doctors training to become rehabilitation physicians across Australia and New Zealand. So please welcome to the stage and give a big rousing applause for Dr. Claire Panagata.
Thank you, Tim. What an intro. And thank you for all coming tonight. I am acutely aware of the wealth of experience in this room, both clinical and lived experience. So it's an absolute pleasure to talk about changing the lives of people with spinal cord injury in this forum. Spinal cord injury is a cause of profound disability. It affects a wide range of body systems, results in diverse psychological and social challenges for people, and puts people at risk of specific complications across the lifespan. But it is widely recognised that a society's infrastructure, its laws, its attitudes and beliefs can either exacerbate or reduce the degree of disability that people feel. Increasing awareness of the condition through forums such as tonight can really help to improve the support for people in Queensland communities with spinal cord injury. So the spinal cord is the information superhighway of our bodies. It's comprised of nerve fibres that transmit information, only some of which we have conscious awareness of, from our brain to all parts of our body, and from our bodies back up to the brain. It's protected within a tunnel formed by our bony vertebrae, so our backbones, with off-ramps and on-ramps for peripheral nerves to exit and enter at each level. So this is an MRI of a normal spine. It's 2 images of the same person's spine. So we can see just 2 computer algorithms essentially which highlights different features of the anatomy. We can use bony landmarks such as the base of the brain here, the back of the neck, the chin here and front of the neck to orientate ourselves. And we can see down the centre there's this row of building blocks. That's our bony vertebrae with discs in between each bone. And that's attached to an archway. Essentially, we're looking from the side of a person, pretty much down the middle of their spine. That archway at the back and the bony vertebrae at the front form a tunnel, and within that tunnel, the spinal cord is contained. The spinal cord is this grey structure here, which attaches to the base, our brainstem, and goes right down, sending out nerves at each level. Spinal cord injury occurs when damage to the spinal cord interrupts the transmission of these nerve signals. The causes of spinal cord injury are diverse and are commonly divided into those that result from a traumatic event and those that result from a disease or a disorder. Often those with traumatic injuries have bony fractures or dislocation of the vertebrae, which causes damage to the spinal cord contained within. People with non-traumatic spinal cord injuries often feel that the term injury doesn't really apply to them. They could have been doing something as mundane as hanging out the washing when they had an acute onset of neurological symptoms. So the term spinal cord impairment is probably more accurate for this population. Now, the higher up the spinal cord the interruption has occurred, the more body systems are involved and affected. The term tetraplegia or quadriplegia refers to spinal cord injury in the neck, and this results to a loss of feeling and motor function in the arms, the trunks, the legs, loss of function of the pelvic organs, and sometimes loss of motor function of our diaphragm or our breathing muscle. Paraplegia refers to spinal cord injury below the neck, in which the motor and sensory function to the arms is preserved, but the trunk, legs and pelvic organs are affected. Depending on the severity of damage to the spinal cord, some messages may still traverse the damaged segment. So people can be impacted in a vast variety of ways. So we're fortunate enough at the Spinal Injuries Unit at the PA Hospital to have been collecting data on admissions to our unit for the last 40 years, so since 1980. Hopefully you can see that on the left there's 1980, 81, and on the far right there's 2021, 2022. Now, I've just pulled the traumatic causes of spinal cord injuries here, and we can see that the two most common causes are the blue line, which is road trauma, and the red line, which is falls. Now, road trauma includes push bike accidents. It includes incidents involving pedestrians as well. Now, the green line is diving or surf-related accidents, and unfortunately they are all too common in our Queensland summers. This mechanism of injury almost always results in tetraplegia, so an injury to the neck, and it can be devastating. Horse riding injuries and football injuries are also represented here as the purple and light blue lines. And they're much less common, but we still get incidents each year. So this is our data for a much shorter period of time, just the 4 years from 2017 to 2021. This is for people who have experienced spinal cord injury as a non-traumatic cause, from a non-traumatic cause. And most often people requiring admission to our unit with these injuries had abnormalities of the blood supply to the spinal cord, so that's the vascular bar there. So that might be essentially a loss of blood supply or a stroke, or abnormalities of the blood vessels. Frequently it was related to issues with the intervertebral discs, so the discs between the vertebrae, or infection in the spinal canal, and these two causes can cause compression of the spinal cord. Unfortunately, we don't have a cure for spinal cord injury as yet. So certainly when it comes to traumatic causes, prevention is key. If we can prevent the trauma, we can prevent what we call the primary injury, which was when the majority of damage occurs in the spinal cord. Following the traumatic incident, we know that inflammation and swelling around the damaged area can worsen the injury, and this is called the secondary injury. So the secondary injury is a target for research, such as Mark and Ellen's research that we'll be hearing about tonight. And the aim is to essentially increase the likelihood that people will get neurological recovery in the first few months after an injury. Now, these are the road trauma, the data from our unit since 1980. So the importance of effective public health messaging and legislative change on reducing trauma is really clear when you consider this data. So advances in reducing rates of drink driving, reducing speeding and improving seatbelt use have drastically changed the proportion of people suffering spinal cord injury from road trauma in Queensland. The other interesting change it's quite a dramatic change we've seen over that period of time is regarding the age at which people tend to be having their injury. So this graph takes a snapshot of a 1 year period, a decade apart, over those 5 periods. So you can see in the 80s and 90s, at least from that snapshot, there is a very significant trend towards younger people aged 16 to 25 having their spinal cord injuries. And now we can see in the present day that trend has very much shifted to people in the over 40 years age group. So the general public can fairly quickly recognise the motor and sensory changes that occur after spinal cord injury. And improving motor and sensory function is a really important part of people's rehabilitation. But as you can see, it really is just the tip of the iceberg in terms of the broad impacts of this type of injury on people and their families. It's also important to note that each injury is different. So with regards to exactly which nerve fibres were affected, the severity of that damage, and the person-specific factors that impact someone's ability to participate in rehabilitation. Some people with spinal cord injury can return to walking. They might not have a very visible disability. However, the loss of bladder and bowel control can have catastrophic effects on their willingness to leave their home, their willingness to participate in their community, their relationships and their mood. Therefore, our rehabilitation needs to be very person-centred in its approach. Now, the rehabilitation process for people with spinal cord injury is a protracted one. As you can see from the graph on the left, this is the average, or the blue bars are the average length of stay in our spinal injuries unit. And in 2018, 19, 2020, 21 and 21, 22, the average length of stay was 124 days in hospital, or in rehab, I should say. The process really prepares people to live outside of hospital, and that's not something that happens quickly. It takes a large team of doctors, nurses, OTs, physios, social workers, psychologists, dietitians, speech therapists, leisure therapists. The list goes on, and peer support workers are incredibly important as members of that team. So peer support workers provide that lived experience, that knowledge that clinicians cannot give people who are about to enter the world with a new disability around how to manage all of those day-to-day things, how to get back to the things that people love doing. The focus is on trying to teach people as much independence as possible, despite their loss of functional ability. Prescription of specialised equipment, formal care supports, major home modifications, and identification of funding to support all of these requirements are important parts of rehabilitation. And really critically, we aim to teach people and their families as much as possible about their own injuries so they can become experts in their condition. This empowers people to self-manage many of their health and aspects of their care day to day. And we know that a person who's really engaged in self-managing their condition has a reduced chance of complications and also an improved quality of life. So, with improved management of secondary complications associated with spinal cord injury, the mortality rates for people with SCI has been decreasing since the 1970s. To maintain healthy lives and manage the complications that can occur, people with SCI are frequent users of our health system across their lifespan. So to support this, the Queensland Spinal Cord Injury Service has a model of care that essentially provides a continuum of support from the time of initial injury and then lifelong. This is a diagram of our model of care. So we have the person with the spinal cord injury in the middle of that equation. They have a network of support that's a combination of formal and informal support, so their family, friends, colleagues, their local health service and their therapy providers, and also their care providers who might come into their home to support people. Encompassing all of that is our public specialised health spinal injury service, essentially to assist anyone involved in helping someone with spinal cord injury. As people live their lives, their goals will change. The focus will often shift from adjusting to life with a spinal cord injury to living well despite their spinal cord injury. At this point, goals of fertility and parenting, returning to work, participating in leisure activities, participating in sport, come into focus. What we know is that with a robust network of support, as we've talked about back here, and with access to a specialist spinal cord injury service, people with spinal cord injury have the best chance of being active contributors to society and living full and meaningful lives. And I'm going to leave it there. Thanks.
Thank you very much, Dr. Claire. It is wonderful to work alongside you and your team at the PA, and to be included as a peer support along the other clinical departments. It's wonderful to work together to be able to help new patients in there and their families and their communities. It's nice to sort of sit back and see that journey all put together, because 23 years post-injury, you kind of forget a bit about that beginning, that first injury stage. So thanks very much for your presentation. I'd now like to welcome to the stage our next speaker. Can I please invite up Ellen Gillespie, who successfully completed her honours research with the Rutenberg Lab in 2017 and then returned to the lab in 2018 to begin her PhD. Her work focuses on investigating the mechanisms of action of a therapeutic called IVIG. Big breath, Tim. Get this one right. You're a singer. You should have good diction. Get ready. Intravenous immunoglobulin.
Yep, perfect.
Oh, we got through it. Anyway, she's specifically aiming to understand how IVIG works to improve recovery from acute spinal cord injury. So please welcome Ellen Gillespie.
Thanks, Tim, and thanks, Claire, for a great talk. I'm actually not going to talk about IVIG today at all, so you don't have to remember what he said at all. So I am, though, going to be talking about how in my PhD I've been trying to understand the inflammatory response following spinal cord injury. And I'm going to focus particularly on the first week following spinal cord injury, so that acute phase where that secondary injury that Claire mentioned really starts to propagate. So the primary injury is, as Claire already said, is what happens at the time of the initial mechanical impact. So this causes immediate and irreversible cell death. The secondary injury is the phase that happens in the weeks to months following that initial impact, and this causes damage to tissue that was originally spared following that initial impact. So our lab focuses a lot on trying to understand this secondary injury phase, and the idea is if we can understand exactly what's driving it, then we can come up with treatments to prevent it. So one of the major causes of secondary injury following SCI is inflammation, and like I said, a lot of this inflammation happens in the first week of injury, so that's where a lot of my research is focused. So after a spinal cord injury, immune cells, which are normally patrolling just in your circulation in the blood, they'll be triggered to leave the blood and enter into that lesion site. Here, they'll encounter a whole range of different inflammatory triggers. So they'll see things like the dead and dying tissue that's been damaged from that actual impact. And this will cause them to become activated and start trying to kill off that other healthy tissue. They'll also start interacting with cells that were already living in the spinal cord, and together this creates a really complicated microenvironment that propagates that secondary damage, and a microenvironment that we don't really understand at the moment. So, like I said, propagates that secondary damage, but some aspects of this inflammation is actually really important for wound healing. So this means that we can't just completely suppress this immune response to spinal cord injury, and instead we want to come up with immunomodulatory therapies that can try and suppress the damaging aspects of that response and at the same time increase the wound healing aspects. And in order to do this, we need to understand exactly what's happening in this response. So here you can see a picture of an injured spinal cord from a mouse, and you can see all of those infiltrating immune cells here in green. So this is a picture that I just took on the microscope. It's one of the kind of traditional ways that we try and look at what's happening in the lesion. And with this kind of information, we can figure out the major cell types that infiltrate into the lesion site. So we can see, I've listed a few of them here. You might have heard of things like B cells or neutrophils before. We can have a general idea of where these cells go and what they are kind of doing once they get into the lesion site. But the problem with this kind of technology is that we kind of need to know what we're looking for. So if I want to know what a neutrophil is doing once it gets in the spinal cord, I need to specifically look for that neutrophil, and I kind of will lose all the other information about all the other cell types and how they might be interacting with that neutrophil. We also don't really know how all of these different cells respond to different treatments. We don't know how they react at different levels of injury, so in a high versus a low level spinal cord injury. And we don't really know how they're communicating to one another. So a lot of my PhD work has been trying to focus on these new technologies that have come out lately, which I'm going to show you two of today, to try and answer these questions on a deeper level than we've ever really been able to before. So the first thing that I'm going to talk about is single-cell transcriptomics, so you don't have to remember that word either. But basically what we do is in our mouse model, we'll dissect out the spinal cord and pull out the immune cells that have infiltrated, put them into a tube. Then we'll look at the gene expression of every single one of these cells that we've isolated. So from this information, we can look at every single individual cell. We can see what genes they're expressing. We can look for new cell types. So previously, when we were looking for, say, the neutrophils, when we had to know what we were looking for, we couldn't really discover any new cell types. But with this way, it's kind of an unbiased approach, and it's going to tell us everything that's sitting in that lesion site. We can look at the function of every one of these cells, and then we can combine all of this to figure out how these cells are changing as the injury progresses over time. So here's an example of some of the data that we've created from this technology. So it's kind of hard to see there, but every single one of these dots that you can see is an individual cell that we've pulled out of the spinal cord. And we've got the gene expression and function information for every single one of these cells. So we found all of the kind of major cell types that we thought that we would find that we kind of already knew were in there. But what was kind of cool with this was that we actually found, instead of there just being, for example, neutrophils in the spinal cord, we found that there was actually 10 different types of neutrophils. And every different type was making a different thing, had a different function, and is interacting with all of the other cell types differently. So this is like really great for us in terms of understanding a lot more of what's going on, but also complicates things a lot more as well. So the second technology I'm going to talk to you about is called spatial transcriptomics. So this is really similar to the single cell that I was just talking about, but in this case we're not actually pulling out our immune cells, we're leaving them intact in the spinal cord. So in our mouse model we can section up the spinal cord, put it onto a slide, and this means that we get to leave the immune cells sitting within the lesion where they were just naturally in the body. We also get to look at our CNS or our spinal cord resident cells, and we can see how these two different cell types are interacting. So this was information we lost when we pulled out just the immune cells in that spatial technology that I just talked about. So we also then can look at the gene expression across the whole tissue for this, doing this type of technology. And then we can map where all of the cells are sitting in the tissue and see all of the genes that they're expressing. So this means that we can figure out how they're influencing each other and what they're making. So here's an example of some of the data we've got from this type of experiment. So you can see the purple in the background is the spinal cord tissue, and then each one of these circles here is a gene expression data. So we can figure out that we've got a cell type A sitting up all along the top of the lesion here. We've got this pink cell type B kind of clustering all throughout the middle of the lesion, and then we've got a combination of A and B sitting around the outside. We can also see what these cells are making in the lesion, and we found that, for example, there's a few cells sitting right up the top here that are making really high levels of these scarring proteins. But you can see there's only a few of them, and they're kind of right around the outside. So something kind of really interesting that we found using this spatial transcriptomics data was that where the cells were sitting was actually completely changed depending on if you looked at a low-level injury. So the first one I showed you was a low-level T9 injury. But when you look at a high-level T2 injury, you can see that we've got this big giant core of the cell type A sitting in the middle, then these are surrounded by cell type B, and then we've got the combination of A and B on the outside. And we also found that in our high-level injury, we have a whole heap more of these scarring proteins being produced, which is something we might not have thought to look for before when I said we had to kind of know what questions we were asking in the past. This data is actually able to tell us that one of the biggest differences between our high-level and our low-level data sets is that we've got more of this scar protein sitting in our high-level injury. Now, what this means and how important that is for functional recovery, we don't really know at the moment, but it's really something interesting that we'd like to investigate. We did also confirm that we confirmed this using our normal, traditional microscopy techniques, where we saw, again, this increased amount of these scarring proteins sitting in the high-level lesion. So just a summary of this first part of the talk so far. So these new technologies are really exciting, and they can tell us kind of for the first time what every individual cell is doing, where they're sitting and what they're making and how they're talking to each other. But the question now starts to become, what are we going to do with this information? So like I said, some aspects of this response cause further tissue damage, while some are important for wound healing. So the idea is if we can understand exactly what is happening and what's driving that secondary inflammation, we can figure out the cells and pathways that we want to target to try and prevent the tissue damage, enhance the wound healing. And we'd go about this by either identifying drugs that might already exist in the clinic that we can use to target these pathways, or we can come up with new therapeutics. So now, just for the final part of my talk, I'm going to give you an example of a way that we're trying to target one of these pathways in the lab. So this is Dr. Laura Grice here. She's our amazing bioinformatician that's done a lot of this analysis for us. And she came up with these very complicated but cool-looking plots, which basically just tell us that neutrophils, which are one of the immune cell types sitting in our spinal cord, are talking to macrophages, which is another immune cell type. And she found that these neutrophils are talking to our macrophages via this molecule called ANXA1. So this is really cool because ANXA1 is an anti-inflammatory molecule, and it's been shown to prevent secondary damage in models of stroke. So we might think, okay, awesome, in the spinal cord, this is already being made. But the problem seems to be that only some of our cells are expressing this ANXA1. So we think, our macrophages can clearly respond to it because our body is naturally making it, but maybe we just don't have enough of it. So we thought, okay, what if we try and target this particular pathway to prevent that secondary damage by creating a synthetic version of ANXA1 and then injecting it into our mouse model. Okay, so this graph here shows what happens when we did that. So basically, it is a functional recovery graph where we had mice with a spinal cord injury. We treated them with this ANXA1 treatment, and then we looked at their recovery over a few weeks post-injury. So you can see we gave them a score of 0 if they had complete hind limb paralysis, and they get a score of 6 when they can start to step. So in our control group, so these mice just had a normal control treatment. They end up with a score of about 3.5, which is pretty normal, and they'll plateau about at that score. Then when we treat with our ANXA1, our scores go up to about 4.5 to 5. We even had some mice scoring a 6, which was amazing, which suggests to us that we can, might be able to target this pathway in order to decrease that secondary damage from happening. Well, so that's pretty much it. I'll just do a quick summary of what I've talked about. So the inflammatory response that happens after spinal cord injury, and particularly in that first week post-injury, is very complicated. There's wound healing aspects, but also damaging aspects. These new technologies that are coming out are now allowing us to profile the immune response on a deeper level than ever before. And we've already identified that there's multiple immune cell subsets sitting in the spinal cord, and we found there's increased scarring in a high-level injury compared to a low-level injury, but we don't know why yet. And we're hoping that we can use this information to then develop targeted therapeutics that can prevent these these pathways that cause secondary damage. And already ANXA1 seems to be one possible pathway we could target. So all in all, this does generate a whole heap of data. So we're currently at the phase where we are trying to sift through all of this, figure out which pathways are actually worth targeting, and which ones are best to explore to try and prevent that secondary damage from happening. Also, thank you.
Thank you, Ellen, so much. Wow, that was interesting. Incredible work that you and your team are doing, so thank you very much for your presentation. I'm sorry I got the introduction notes wrong. No, that's okay. I practiced for 3 hours to try and get that word right. And I'm never going to have to probably use it again. That was really amazing, so thank you very much. Please give her another round of applause. Ellen Gillespie. Now it gives me great pleasure to welcome to the stage our third speaker for tonight, and that is UQ's School of Biomedical Sciences Associate Professor Mark Rutenberg, who heads the Neurotrauma Research Group. His research focuses on the body's response to traumatic injury, including spinal cord injury, and the role of inflammation in the recovery from this trauma. Associate Professor Rutenberg works closely with other scientists and clinicians to address these issues with the ultimate goal to link immune cell function to neuropathology. See, I got the other word right and then I get this one wrong. Neuropathology, and to find new and innovative ways to better treat neurological conditions that currently have no cure. So please welcome to the microphone Associate Professor Mark Rutenberg.
Okay, thank you very much for that kind introduction, and also to all of you for being here tonight. So I'm going to change gear a little bit and actually talk to you more about translational challenge that I think that we face, not just in terms of discovering new treatments, but in terms of bringing these treatments actually into the clinic. And this is prompted in a way in part by some of the clinical studies that we have been involved in. And I think also what I'm hoping to show you and convince you of by the end of the talk is how I think we're on the verge of changing this problem in terms of bringing new treatments into the clinic. So this slide you have recognized in part before, so I don't have to talk about the concept of primary injury and secondary injury anymore. But what I do want to highlight is that I think we've struggled for a long time to, in a way, take research findings from the lab into the clinic. And so some of you, I met Dr. Vernon Hill tonight, have been around for a lot longer than me and would have known that a long time ago we thought we would be treating spinal cord injury with steroids, and that would do a whole lot of good in terms of suppressing that inflammatory response. And the results have actually been quite disappointing in that sometimes there was an indication that it worked, but there's a lot of controversial data out there that actually says it doesn't work at all so well. Or that in some patients it may actually even cause adverse complications. And so I think we've come a long way, and I think Alan's talk phenomenally touched on that in terms of like how we understand now what happens inside the spinal cord, the complexity of the inflammatory response, and also that suppressing inflammation sort of broadly is not going to be the way forward, because we need aspects of the inflammatory response to drive healing inside the spinal cord. And so what we really need is immunomodulatory interventions, so interventions that can actually dampen down the bad but still harness the good. And that's where the intravenous immunoglobulin comes in, which is a treatment that we discovered in the lab, that we've been able to take into a world-first clinical trial here at the PA hospital, and hopefully we should be able to publish the results in the year ahead. But I think it's also fair to say that, as I said, that we have had these difficulties, and I don't think it's necessarily because the treatments that we have been using were not the right ones, but also think that there is another problem, and that's what I want to talk about tonight, and that's the vast clinical heterogeneity that we see in the clinic. And so no patient, and that was already said earlier, really is the same. And so that poses a problem to us because, for example, like when we look at our patients that did get IVIG therapy and we see some recovery, then we say, well, did that recovery happen because of the treatment that they got, or was that always on the card? And so at the moment, we just don't know. And you can see, like up there, there's like 3 MRIs of people that sustained a spinal cord injury. They're all cervical injuries. They're all different. And believe it or not, the one on the right-hand side actually recovered the most. So really what this is telling us is that we have very little to go on at the moment as into how well a person is going to recover. And so in the end of the day, we need to be able to prove scientifically that our treatments are working. And so that's really a gap or a problem that we have on the clinical side. So what I'm going to hopefully convince you of tonight that we are close to fixing that issue. But before we go there, I think it's also important that we don't have this problem not just on the acute side of injury when a person is just injured, but even I think when people are beyond that acute phase, I think there is a need to understand people a lot better, particularly when we think about rehab approaches, which I'm sure that Associate Professor Sean Tweedy will talk to you about in the next talk, and also the importance of engaging in exercise. So this was a study actually from Sylvia Gustin's lab down in Sydney with really striking results actually. So what she did, she took about 23 individuals, or exactly 23. They were all Asia grade A, so that means that they have no ability to feel from below the level of the lesion. They have no motor function. And then what she did without these people obviously being able to see that, they would stimulate the big toe. And if you just focus on the bottom panel, and maybe I should, I'll grab a pointer, I'll point it out here. You can see that normally if you do this in a healthy individual, you get activation of brain regions that normally would process this sensory information. And what was really the surprising finding of this study is that in about almost 50% of the patients, we could actually see an activation signal in exactly the correct brain regions that would normally be processing this information, even though the patient was completely unaware of it. So this is telling us that in these patients there is spared pathways, spared tissues that are dormant, but that we can still probably make to work probably with the right rehab technologies. And so what this really drills home, I think, is the importance from the very outset to try and protect and preserve as much tissue as there is. But also when we think about rehabilitation approaches, for example, and also we hear a lot about electrical stimulation these days, how well is a person going to respond to that, and how much does this play into it in terms of how complete or incomplete these lesions are anatomically. So if you think about how we are diagnosing spinal cord injury at the moment, is really what we do is we would focus really, I would say, on the pathology side of things. So we would use classically like MRI, sometimes a CT scan, to diagnose the level of the injury, so we can see the damage to the spinal cord. We supplement that with a neurological examination in which we assign basically a grade to that individual based on the level of disability that they have. But what this information really isn't telling us is the right granularity that we need as to how badly that individual was actually injured at a finer level. Also what is actually happening inside the spinal cord. And another complication, particularly early on, is that many of these patients are in what we call so-called spinal shock. And that means that all function at and below the level of the lesion site is transiently suppressed. And that's again a problem for us because it means that if we see again recovery, it may just be a return of function because the spinal shock is resolved. And so at the moment we actually, well, we can test when the spinal shock resolves, but we have no way of knowing from the outset how much tissue is going to be spared and what we think might be, what function might be returning. The other thing, because there is spinal shock, is that we also actually cannot functionally monitor the progression of secondary injury because we can't actually see a neurological status further deteriorate because there is already a complete loss of function. So what I'm going to talk to you about tonight is two stories that we've been working on. First of all, how we can actually use immune cells in the blood, so not necessarily the ones that go into the lesion, but at the level of the blood, to determine, in a way, how they respond to spinal cord injury. And the good thing about immune cells is they actually act as sensors normally in the body. So they are normally programmed to respond to things like infection, but also to tissue damage. And so we will see a response. And the question that we asked ourselves is, well, how does that link, in a way, to recovery or outcomes? And the second part of the talk, for the final few minutes that I've left, I'll focus on how we can actually use what we call now structural biomarkers. So proteins that will come out of the spinal cord itself, and to detect actually the amount of damage to the spinal cord and how much of a prognostic value that has for us in terms of like predicting outcomes. So for the first bit, I'm going to talk to you about some work that we did. And the good thing about looking at immune cells is that we actually, or the clinicians will actually routinely collect this information and people get admitted to hospital. So a talented PhD student that we had in the lab, so Dr. Tricia Jogia, who's now studying medicine here, she actually looked at just starting off by asking a very simple question, going through all this clinical data that was already collected, by saying, like, if we look at white blood cell counts and we compare that to the injury characteristics of those patients, can it actually tell us something about injury severity and also the longer-term outcomes? And so this is all published work, so I'm going to cut straight to the chase in terms of the graphical abstract. And so what Tricia discovered is that actually there is very distinct responses of immune cells, different types of immune cells, how they respond to injury. So a particular type of immune cells called neutrophils, and there's a bit of a complexity there that we can talk about in question time. But at the level of the blood, we see that there is actually a profound acute neutrophilia. So that means that there is an elevated number of neutrophils. And what Tricia found is that that actually links like negatively in terms of the long-term recovery of those patients. So she did very complex statistical modeling where she not only looks at these immune cells in isolation, but she would take into account like the trauma severity, the level of injury, the severity of the neurological grading, whether it was a patient with an isolated spinal cord injury or a multi-trauma patient, the age and sex of the patient. So all of that went into that formula. And then ultimately she found that she could actually predict with quite a good accuracy, whether that patient was likely to have a substantial degree of recovery, so an AIS grade conversion or not. And overall neutrophilia was negatively associated with grade conversion. What was quite surprising, though, is that she also found that lymphopenia, so this is another type of immune cell, and just lymphocytes we're looking at now, and so a patient with lymphopenia will classically have a lower number of lymphocytes, or these blood cells, at the levels of the blood. And so what she found is that lymphopenia actually is actually positive. So the patients that develop lymphopenia typically would have a better recovery in the longer term, so they would show an AIS grade conversion. And that was somewhat surprising to us because lymphopenia is typically associated, certainly in critically ill patients, with like bad outcomes. So the problem is, but this is all being routine blood data, that we don't actually have the granularity again here to appreciate what's going on because there are many different types of lymphocytes. So Tricia then took this further, and what she then did, she actually started a prospective study in which she began to recruit patients through the hospital, the spinal injuries unit, and also the trauma department already very early on. And she actually started banking the blood so that she could actually do much more specialized analysis in the lab to look in much greater detail as to what was happening in response to injury, particularly in relation to, for example, these lymphocytes. So she developed a 25-color flow panel, so she can now use 25 different colors conjugated to antibodies to stain all of these cells and then very precisely find out what is actually happening in each of these individuals as to how they respond to injury. And there's a lot of complexity in this data, but I'll just cut to one of the key points, is that, so you can see there's an enormous diversity of different types of lymphocytes, but if you just focus on this, so this is a healthy control person in terms of like the types of immune cells that you would have. And you can see that following spinal cord injury, there is a clear expansion of this red quadrant, or not, it's not a quadrant, this red part of the pie here. And so what she found is that these are CD8 positive T cells. So these are cytotoxic T cells that normally kill cells, kill other cells. So when it's a viral infection, that's a good thing. In autoimmunity or other conditions, that's usually a bad thing. So she then took this a step further and actually now looked specifically at what is happening in the patients with spinal cord injury. But what she did now is actually she split the patients out between those where the lymphocyte number stayed within a normal range based on routine pathology results versus those where they actually saw a clinical lymphopenia. Remember that that was associated with a better outcome. And so what she found is that specifically now those CD8 positive T cells, so these cytotoxic T cells, we don't actually see a response in those patients that typically have a better recovery. So they seem to be suppressed, and we don't really understand yet why that is. She also found a similar phenomenon for B cells. But overall, this is giving us not only an indication as to how we can use immune cells in a way to predict injury severity and also recovery, but also in a way it gives us a clue as to what immune cells that we maybe should be studying in the lab further to understand how they influence lesion site development and recovery in the longer term. So I'm going to change now back to the second part of the talk and talk to you more about these structural biomarkers, because obviously the thing about immune cells is that they're very generic, and so they are not, the responses that we see are not, they're obviously responding to the spinal cord injury, but they're not specific to a spinal cord injury. Like for different traumas, you can see similar responses to some degree. So the structural biomarkers, what we're doing at here is we're now actually looking very specifically at proteins that actually are normally present inside cells that reside in the nervous system itself. So these can be nerve cells, or they can be glial, like supporting cells. And when the tissue becomes damaged, these proteins will now actually be able to leak out into, for example, the cerebrospinal fluid, CSF, or also the blood. And so what we can do is we can actually look for these proteins there and we can measure them. And the one that we are really excited about and that I want to highlight to you tonight is a molecule that we call neurofilament light. And so neurofilament light is a structural protein. It's normally present inside nerve cells. And so what happens is when nerve cells become damaged is that that neurofilament protein is now actually leaking out. And so we were able before to actually detect it like in the blood, in the CSF, and not naturally the concentration in the blood is much lower than what you would see in the CSF. But the technology has so much advanced, and this is work done again by Trisha Jogia and also Esther Kulamai, a former research assistant in the lab, is that we can pretty much now, with the technology machine that we purchased that we were able to obtain last year with support from UQ, is detect pretty much at single molecule sensitivity these proteins at the level of the blood. And so if you look now in human blood, so in plasma from human patients, you can see that there is a vast elevation following spinal cord injury. This is on the first day following injury in patients that sustain a spinal cord injury. You can also see that if you compare, this is the healthy control, that in trauma patients, so those with no known brain or spinal cord injury, we don't actually see that elevation. It stays very much the same to control levels. Now, you may also see that there is a very significant spread in terms of the data points, and that's actually clinically significant because that spread, as I'm going to show you now, is directly correlated to the amount of damage that was sustained by that individual. So what we did here is we actually split our patients out based on the early admission data, whether they were diagnosed with a complete motor paralysis, so no motor function left below the lesion, versus those that still had retained some motor function below the level of the lesion. And you can already see that very early on, at 1 day after injury, we can clearly separate out those patients. So we can see that those with a motor complete injury already have significantly higher levels of neurofilament than those with a motor complete injury. And that's important because sometimes patients cannot, for example, comply with a neurological examination for a range of reasons. And we actually have different ways now how we can actually assess the amount of damage. And that's again important, particularly when we do early interventions, where we obviously need a lot of data. The other thing that was quite surprising to us is when we actually look now at what is happening like over time, is that the amount of neurofilament actually kept going up for days, and it stayed up for many weeks post-injury, at least up until 21 days. It seemed to be starting to come down by about the 6-week mark. And so what we think that this is actually reflecting is the progression of secondary injury and the ongoing loss and degeneration of nerve cells that we see, or that we know to exist from animal models, but we think we're actually seeing it in human patients here for the first time. Now, we initially thought, well, maybe it's just sort of like debris that's sort of like leaking out of these lesion sites. And we thought, well, if that was true, then we would see the same for proteins that would not be specific to neurons, but let's say would be specific to glial cells. And so when we look at another marker, which we know is actually coming out of the glial cells, so like the support cells of the nervous system, we actually again see that they are elevated in response to injury, but you can also see that they very quickly come down again to baseline. So we think it's not just a passive leaking, we really think that this is an active sort of ongoing degeneration process. Again, what you can also see here, that even these glial markers have some prognostic value, in that the patients that had low levels typically will go on to have an AAS grade conversion, and those that had very high levels, we said bad outcomes, so that means no AAS grade conversion during their time in hospital. And I think what was quite exciting is if we go back now to the neurofilament levels, what we were actually able to show, and we pretty much were finding this at every time point during the first week, whether we looked in admission bloods 1, 3, or 7 days after injury, we get a direct inverse correlation between the levels of neurofilament that we can detect in the blood versus the final motor score that that person is going to leave the hospital with. And also when we look at the change in motor scores during their time in hospital, we find exactly the same. So we think that really for the first time now, we have a marker that can tell us about injury severity, that can stratify patients based on how badly they're injured, and also it's going to tell us like how likely that person is going to recover and what the degree of recovery might be. And that's obviously going to be critically important when we actually try to assess therapeutic effectiveness. So I think, so things to take away. Hopefully I've convinced you that immune cells are not just important in terms of like obviously what's happening at the lesion site itself, but that even whilst they're in the blood, we can use them in a way to look at some diagnostic criteria or how well we think that a person may or may not recover. I didn't really touch on that, but we see also long-lasting changes in the blood profile of these patients. So even if the pathology results basically say that everything is back in the normal range, that when we actually start to look at individual subsets of immune cells, they're clearly not back to normal. And also what we have found is that so people that seem to be doing better longer term typically have a very low B cells and cytotoxic T cells early on. So that's something that we can take further now in terms of our studies. In terms of the structural biomarkers, so I've shown you that we can detect these in the blood, that the levels are directly proportionate to injury severity, that we can actually monitor the ongoing degeneration that is happening, which is seeming to persist for many weeks post-injury, and also that these levels are really prognostic in terms of the degree of recovery that we see. And so I think that what we really need is that we really need to think about how, not how, but we must really start to include, I think, these sort of tests and analysis in our ongoing management. And so we need to really build, I think, prospective registries by which we can really look at each individual patient and actually characterize that individual by the severity of the injury. And with that, we can then also start to rethink our clinical trial designs by actually using randomized clinical trial designs, but actually looking back now at prospective registries where we can actually match individual patients up to the correct ones that they should be matched to in terms of the injury characteristics and also the severity of the injury that they had. And hopefully with that, we can actually compare the right individuals and then actually see that, yes, our treatments are working or not. So with that, I would really like to thank the people in my lab that have done this work. So I already mentioned Tricia and Esther. Esther Jacobson, another Esther, was our clinical trial coordinator. I would like to very much acknowledge our clinical collaborators, specifically spine surgeon Kate Campbell, James Walsham from the intensive care unit, Sudara Tress from the spinal injuries unit, and also Emily Gollan from there. And then last but not least, our funding agencies, particularly Spinal Cure Australia, who's made all of this work possible. Thank you.
Thank you very much, Associate Professor Mark. Yeah, what great discoveries and exploration, and very excited to see the future of that and the early diagnosis and translation into what that means for treatment in those early stages. So congratulations to your team, and thank you very much for your presentation. Our final speaker for tonight, he's up and ready to go. Look at this. Can I please welcome up to the stage our last speaker, Professor Sean Tweedy, who leads the Parasport and Adapted Physical Activity Research Group in the School of Human Movement and Nutrition Sciences at the University of Queensland. Through his applied research program, he aims to generate the knowledge required to empower people with disabilities to pursue self-directed goals through safe, effective engagement in sport and physical activity. So please welcome Sean Tweedy.
Thanks very much, Tim. And I think we'll bring the language level down today. You won't learn any new words in this.
There's plenty of question time afterwards. So if you need any clarification of what words mean, we can go with that afterwards.
This is where I'll end up here, sort of a sporting partnership between people with spinal cord injury, clinicians and researchers, I think, as a model, a prospective model for helping us to move forward overall. For my presentation today, I've got three main parts. I'll look at muscle atrophy and muscle hypertrophy, separate those for us, make sure that we're across those terms. I'll look at sport, at Parasport, and the Parastart program, which is our sort of flagship program at UQ that I've been running for the last 5 years, and then the future. And I think revisiting, you'll know this. I'll tell you a little bit more about this name later. It's Ludwig Gutmann. His vision and what I think we can do to recapture and reimagine that. And there's a bit of a clue here. So this is from the 1948 Stoke Mandeville Games in Aylesbury in England, and this is from 2022 Wheelchair Rugby Nationals in Brisbane. So we'll be sort of spanning those and seeing where we can go to from there. So we've got. If you've got the concept, the normal muscle in the middle here, atrophy is the process by which the muscle becomes smaller and weaker. Okay, so that's the atrophy part of it, and hypertrophy is where the muscle itself and the fibres that make it up become bigger and correspondingly stronger. So from just to look at the atrophy part of that for a second, this is bed rest data from a trial with people who are neurologically intact. So this is just what happens if you lie down in bed for long enough. And what we've got here, we'll just focus on those green bars if you can. What they are the calf. The calf cross-sectional surface, so your gastrocnemius, the cross-sectional area of the calf for people in the control group. In each case, this is from a meta-analysis of 4 studies. In each case, they had a control group who got no intervention, and then they looked at various exercise methods to try and offset the loss of the atrophy that took place. But you'll see. The thing that I want to draw to your attention here is that for people who are neurologically intact, the magnitude of the atrophy that you're getting. So this is between 15 and 20% here in the control group. This is up over 25% here, and nearly a third of that cross-sectional area gone for people who are neurologically intact. So it's a really powerful thing, just that bed rest on top of the secondary inflammation and any of the other the neurological loss that might have taken place. It's a powerful agent. This puts from short-term disuse shows relative muscle mass here, and I'll get you to follow these lines down here. This is actually where this line here is the closest to spinal cord injury, where in addition to that, to people with bed rest, people with spinal cord injury get an additional loss of 18 up to 50% more on top of that, on top of the disuse that occurs, on top of the atrophy that occurs just with disuse. The other part of this plot, though, is the upward trajectory, which can happen. So, following short-term disuse, there is a pathway to recover, and that occurs through resistance training. So, resistance training is an effective, in younger people in particular, an effective treatment for atrophy. And it's for that reason we've got national exercise guidelines for people with spinal cord injury. This was that we published in 2017, and Tim Geraghty, who's the Director of Rehabilitation at PA Hospital, was also a co-author there, along with a number of international authors. And its resistance training is part of the National Physical Activity Guidelines for people with spinal cord injury. But we also know that, like what we've got up here is the Olympic athletes, and down here the para-athletes, this is the hypertrophy part of the equation. The people who have the biggest and strongest muscles in those populations, the most powerful muscles, are this group of people who participate in competitive sport. So really physically demanding competitive sport. So from there, we took that phenomenon, what we know about people with spinal cord injury, and the relative, not only in terms of muscle hypertrophy, but in the other dimensions of fitness as well. So cardiorespiratory fitness, motor skill acquisition, and flexibility. You can get really good returns from sport, and we were interested. We had this story so often from participating in. People participating in sport, that there were these multiple benefits, some of them really clinically significant. So we started the Parastart program, which stands for Sports Training and Research Team. It's a longitudinal intervention that's been running since 2017. So the benefits that accrue in sport happen over not just weeks and months, but years. And they're the periods over which people participate, and they continue to accrue this, increase their muscle mass, their cardiorespiratory fitness. It's a generally upward trajectory, so over a long time, and really big doses. So it's large volumes. So we had 3 participants with severe cerebral palsy. GMFCS is Gross Motor Function Classification System, and it's level 4. Our participants were 5 is the most severe. All of ours were high support needs, which means that they use wheeled mobility, and they need personal support for activities of daily living, like getting dressed and self-care. They were enrolled at 15 to 16 years of age. They were all attending schools. They weren't athletes. That's a really important component. They were brand new. They hadn't been participating in sport, never done a day's training in their life. As of today, they're still training, and we're still getting monitored using a regular standardised test battery, and we're still seeing upward trajectories. I'll get to that in a second. But it's a multi-professional team. It's developed and delivered by a core group with qualifications in swimming coaching, physiotherapy, occupational therapy, and exercise physiology. But it's supported by a medical doctor, a dietitian, sports psychologist, and personal support workers. And it doesn't take too much translation there to see some parallels between the team that we work with and what you might come across in a multidisciplinary team in a hospital. Each of these plots on the left, I'll start with here. Each of them is for a particular participant. And the red line that you can see on the graph, in each case it's in the same place. That's the amount of physical activity required to meet the National Physical Activity Guidelines. So we monitored them each week and recorded how much the activity volume that each participant completed. And this was in the course of 3 to 4 training sessions per week. We were able to. We're still only accruing, we're just sneaking them over in a lot of instances, that barrier. You can see some big weeks there for sure, but they're not massive doses. And so part of the picture here is that people with high support needs disabilities in general have very low rates of participation, and because of that, they're much more responsive to increases in physical activity. So we got the volume of activity, even though it's been very effective, it wasn't huge. This is again, each of these plots here represents a person, and again, the red line is a standardised curve. In this case, it's gross motor function measure. It's a measure that we do regularly with our participants. And and you'll see that that's a downward tracking line. And what that tells us is that the motor function of people with cerebral palsy, and particularly GMFCS, their motor function declines over adolescence in general terms. So our participants, when we enrolled them, that was the trajectory that you would expect them to have followed. And over the 4 years represented on the graph, you can see not only did they, if we'd prevented them from going backwards, that would have been a real something to be happy about. But you can see that they have all improved. They're all upward trajectories, which is really important. So, in terms of highlights, the first is the x-axis. We've got 4 years there. So sport is a very engaging medium. The results were achieved not by getting phenomenal amounts of exercise into people, but just by meeting guidelines. We've got a reversal of the motor decline, and we've got out of that 1 Paralympic qualifying time and 2 others continuing to improve in swimming velocity. So it's an effective swimming program. So I want to now switch back to spinal cord injury, and it's a case study that I know well. So my wife's here today. Our third son, Connor, youngest child, had a spinal cord injury on the 21st of the 7th, 2018. It happened at 1:10 because it was the first scrum of the game, and that's that picture there, and portentously, there's the ambulance that he finished up in after the accident. It was 4 hours later we were getting a report from the surgeon. So after that scrum collapse, it was really rapid back to the hospital. But we got consented onto Mark's trial by Esther Jacobson. Less than 4 hours before we were getting that. Less than 4 hours after the accident. So that's important. You're making decisions. You've got that option there. I think that it's not unrealistic to be looking at the earliest times to be enrolling people in these trials. In August, we shifted down from the orthopaedic ward down to PA. Spinal injuries rehab, where Claire was Connor's treating doctor. So you can see a link here, and Ellen being Mark's PhD student, you can see that there's been one big happy family up here tonight. It's all linked one way and another. Emily's also in the audience. At 9 weeks, Connor got into a wheelchair rugby chair for the first time, and that's that session over there. That's Chris Bond, absolute maniac, an experienced wheelchair rugby player, and that's Emily. Emily's here, is it? You here, Emily? Oh, good on. He was discharged 7 months later. He's still playing wheelchair rugby. 4 years later, he's working, he's driving, and competitive wheelchair rugby is a really important part of his life. In terms of his functional profile, he's a tetraplegic, but he walks short distances. He can cruise around the house. And this is just in terms of independence. I like this clip. The bottom, if you have a look at the bottom right, you can see. Oh, that's a bit distorted. He's not quite that fat. Doesn't put on that much weight. But this is him heading off for he's currently in the US playing a season of wheelchair rugby at the University of Arizona. Yeah, he navigated LA, cleared customs at LA airport and flew to Tucson, Arizona. So he's really off and running independently. So where I think we can go, using that sports model framework for a cooperative approach to explore the upper limits of recovery from spinal cord injury. So it's not necessarily for everybody, but for people who want it, that early introduction of sport, recapturing Ludwig Gutmann's vision. He introduced, parasport became a thing because he introduced it as a novel rehabilitation technique. That's where it evolved from that, but it's been lost a lot in rehabilitation now. It doesn't feature anywhere near as much. That wasn't his vision. I think that we can do it because it features multi-professional. It's got a very similar service provision as well as research dimension. If we get willing participants, consented as early as possible, that would be terrific. And under using a medically coordinated, clinically indicated, individualised interventions across the time course, not only from admission, but as Claire pointed out, that post-discharge and into the community is really important. I think we've got a real opportunity, rehabilitation medicine in general, but spinal cord injury in general, specifically to capitalise on Brisbane 2032. That's where the roots of the Paralympic movement are in spinal injuries. We've got well-established innovative research programs at UQ, but there are also a range of others that we need to collaborate with. We've got functioning partnerships with room for expansion in that. That Mark's also talked through. It's a great process because it empowers participants. You're really the centre of any good coaching program is with the athlete at the centre, multi-professional and multi-dimensional, and to explore the upper limits of what is possible as a harbinger for what might be able to be achieved in the long run by a larger number of people. And again, I think that precision medicine approach that accommodates the heterogeneity and the small numbers that relatively small numbers that we get are really also lend itself to that sports training model. So I'll finish just with my acknowledgements. Certainly in working up that idea, I spoke with Mark a bit as well, and I'll leave it there. We'll go to the panel. Thanks.
Thank you, Professor Sean. If you'd like to stay up with us for the Q&A, but firstly, I did send you through some very athletic photos of myself in my sports days, and there just weren't many in the presentation. You weren't
lost.
Okay.
Yeah.
So 2001 Victorian blow darts champion up on stage here, and if that means anything at all. What did connect with me though was the resistance training component of that, and I only my ears pricked up on that because as a vocal coach and singing instructor with our singing chords program in the spinal injuries unit, some resistance training are some of the vocal exercises that we work on with spinal cord injured patients, and to help them with the expiration of their breath. And so that's exciting to see that not only is that important in sports, but also in the arts and singing. So that was kind of Cool. I made a nice little connection with that. That's great. And we are a really tight-knit family, us spinal team up here. So it's lovely to see so many colleagues and here in the audience. But now it is time for Q&A time, and I hope you've been thinking of questions. Yes? So I'm going to get our guest speakers to come up and join me in these comfy chairs up here. So please welcome back to the stage our guest speakers. And we do have a roving microphone. So if you do happen to have a question that you would like to ask any of our wonderful presenters, please put up your hand and we'll get a microphone to you. Oh, we see we've got one straight away. Yes, good sir.
I'll try and... Can you hear me?
We can.
Good. So sure, there's no doubt that resistance training, sport, other forms of exercise are incredibly important for whether you've got a spinal cord injury or not to good health. The problem with spinal cord injury is often in the early stages of the spinal cord injury, you basically can't move in, and you know, it's hard, you can't do resistance training under those circumstances. It's interesting to look at some of your photographs of your para-athletes, massive shoulders and not their legs. And it's because, you know, you cannot exercise what you can't move. The other thing that you notice is that with spinal Bernard might be able to comment on this. In the early stages of the spinal cord injury, you often can't do anything. And during that time, the muscle loss can be absolutely massive. And even in people who may end up having reasonably good muscle function and would benefit from resistance training, during that early stage they get, basically they lose most of their muscle. I wonder whether there are other approaches to protect people during that early phase. Talking about sport, things like androl, testosterone, puberty growth hormone, IGF-1 and 2, to try to reduce the amount of muscle loss to get through that early phase of the injury, so that you can actually do more exercise, and you're not starting from such a low level where you've lost. You're going to, you know, you lose 60-70% of your muscle.
I think I'll probably dish back to Mark for a bit of that, because I think that it's nice, Phil, in that as enthusiastic about as I am about sport and physical activity, I know that it's not a panacea. It has to go hand in glove with a range of other range of other therapies that are going to vary widely. The component, it ends up being hugely important for the vast majority of the life of the person with a spinal cord injury. The relative importance downstream is way elevated, but that introducing it as early as it can, along with, you know, medically indicated pharmacological or biological management tools, is what I think is where we get all the experts working together to optimise the combination that the combination of therapies that you've got available as you're moving through would be the.
Can I just mention, of course, one of the reasons you get this wasting is, of course, the couple of segments above, which are still lower motor neuron regions, and this does take a while to come down. And that's why we see so many of our tetraplegics, when we manage them conservatively and they stayed in bed sometimes for 3 months, they all lost an enormous amount of weight. But that in itself didn't seem to matter, because once the nerves got back, most of those muscles would work. And that's why one could always be hopeful that even what we would call a complete lesion had that option possibly of getting that little bit more. And at sort of C4, we realised they had difficulty breathing. But once you've got down to C5, you're just getting into the biceps, and then hopefully you're going to get that wrist extension. Because the difference between being able to do that and not being able to do that is that you can be independent with that, and you can really not be independent very much if you just cross the biceps. So I think the difficulty we have obviously is diagnosing whether people are going to be complete or not complete. My people who are actually going to be complete, lifelong complete lesions. Because really we're just insulting them once more with one of the most dramatic lesions already that is then being superimposed by a surgical procedure, which is not going to make any difference neurologically. And that's the biggest message that I wanted to get across, and I believe it's an important one.
Professor Mark, can I ask you to maybe comment a little bit on this? Do you foresee potentially the work that you and your team could potentially work in this field with the earlier intervention with any discoveries that you have made at all?
In relation to?
Oh, just more the initial comment in terms of trying to find ways of making, how am I trying to put this? Helping people in the very, very early stages of spinal cord injuries to actually be more active. So any of your work, does any of the work that you're doing maybe, very future down the track? I know it's very early stages and things, but can you see the work that you guys are doing potentially having an impact in that space?
I think that's really beyond my area of expertise, I think. We really, I guess, are focused more sort of like cellularly, molecularly, what happens. The only thing that I do know is that from experimental studies is that a lot of the acute, so the loss of muscle mass, there's a huge role for the stress axis in that as well. And obviously we do know when someone has a spinal cord injury that there is a massive activation of the stress axis. So in terms of adrenal gland activation, cortisol levels going up. And that's actually driving a lot of very acute muscle mass, like straight up. And we can actually prevent that experimentally if you give in a way steroid. So if you block the steroid receptors, you actually prevent a lot of that very acute muscle mass. But I don't know like longer term. But what I do know, and I guess that was the point that was brought up earlier, is that it does seem to come back. So I don't think it's lost forever. It just, I think with training it comes back. But I don't really know like how quickly it's feasible to get things moving or how safe that even is. So
yeah, I think it's just important to note that those early weeks and months, people can be very unwell as well. So, exercise is often not the primary focus. It's around medical stability. In traumatic injuries, many people have multi-traumas where they might have, rib fractures and abdominal injuries and those types of things as well. So that certainly is significant. And we are, I suppose, historically it was the young, risk-taking male who was pre-morbidly very well, who, I suppose generalise, but who would have these injuries, and so they tend to recover better than probably the proportion of patients we often see now who are older, might have multiple other medical issues which all impact on such a catastrophic injury and that stress response, as you say. There's often less reserve to bounce back from those type of things, despite the neurological change.
Any other questions? Yes. Hi.
Question to the men. I know it's a side question, but how do you inflict the damage on the spinal cord of the mice? And how do you assess it is major or minor damage?
Do you want to repeat the question just as you answer, if that's okay, just in case people didn't hear it up the back? Thank you.
So the question was, how do we inflict the spinal cord injury on our mice, and how do we assess whether it's major or minor damage? So with our mouse model, we have a very controlled and precise surgery procedure that we follow. So our mice are fully asleep. We kind of open up the muscles of the back and we remove part of the vertebra. And then we use a an impactor machine that we can set what force we'd like to impact the spinal cord at. And so then that impactor is basically a piston then that goes down and damages the spinal cord. And so we can choose what force we'd like to set it at. So we do all of our studies in a moderate injury. So that means that the mice can recover a little bit. So in some of the graphs that I showed, they were able to do some stepping. They weren't completely paralysed. But yeah, it's a very kind of a very technical surgery that kind of is very precise, and we make sure it's done the same each time, so it's very replicable across all of our mice.
So it's always there's injury, there's cut,
Yeah.
plus the damage in the.
Yeah.
And this is different to real life.
Yeah. What? No, well, we cut open the muscles and the skin, and then we damage the cord, yeah. So we do sometimes include a sham group where we just cut open the muscles and the skin and we'll break off the bone, but we don't actually damage the cord. That way we can tease out anything that's due to the neurological injury versus what's just due to the trauma of the surgery.
Can I ask you, do you do it at different levels of the vertebrae on the mice? Yeah.
Yeah, so a lot of what we do is down on T9, just so that we can keep it consistent, then we can compare across if we're treating with a different drug or anything. We're always doing T9, but we have recently been looking at doing the higher level injuries and seeing how things are different in those, but it kind of becomes a bit more difficult to do the surgeries when you're changing levels as well, so it's something we've been focusing on a lot in the lab, is trying to figure out how to make those models as precise and replicable across all of our animals.
Consistency.
Yeah, consistency.
Any other questions? Yes.
One question. Thank you all to the panel for your presentations tonight. My question is to you and to Juan. In both of your presentations, you had a cross-section of immune response cells showing up in lighting up. I think it was identified as dendritic cells. I'm curious to know more about dendritic cells in mice and humans. Are they the same? And in your presentations, are you researching the same idea about dendritic cell progression in terms of spinal cord injury?
So in terms of my research, because I look mostly at what's happening actually within the spinal cord, we've actually found there's not that many dendritic cells that enter into the spinal cord, and we don't think that they play a huge role in propagating that secondary injury, so I don't focus on them a lot. And then in terms of them being similar to human cells, they are very similar, but then there's also a lot of differences, of course. So that's kind of one of the things we're trying to figure out with a lot of this sequencing data, is we're trying to compare what we find in our mice to what sequencing data shows from humans and see if they're comparable enough that they will respond to treatments the same way, and if we can then, if we test out a treatment in a mouse, are these cells going to react the same way in a human?
Yeah, I think, so the question, I think the dendritic cells can play a role. I would suspect that it's probably a little bit beyond the period that we've been looking at for Alan's work. So there is some evidence that there may even be a low level of autoimmunity that can develop in people with spinal cord injury. That's more in the chronic phase, so we think that dendritic cells may play a role there. In terms of, I think it is important to recognize as well that obviously a mouse is not a human and the immune system is different. And I think so every model system that we will use will have its limitations. Having said that, I'm also always amazed about how things are sometimes very conserved. So if we come back to neutrophils, for example, which are the predominant type of white blood cells in humans, about 80% of your blood, they'll be the first cells to come in. We know that from post-mortem tissues. In a mouse model, it's probably 17, 18% of, so they are a more minor proportion of the white blood cells, yet they are still the first blood cells that are coming in. So it's a very conserved process, and it doesn't actually matter. And that's, I think, another important thing to understand, is that the recruitment of immune cells into the spinal cord is not passive. So it's not that because there is damage to the cord, the blood spinal cord barriers opened up and cells just leak in. No, they're actually actively recruited in there. And we know that because of the type of immune cells that we find back there. So we don't see them back in the proportion that they're present in the blood. It's actually, and so that recruitment, that is the temporal profile, is very much conserved between mouse and a human. The other thing, which Alan is currently also drafting a paper, which he's probably forgotten about at the moment, but we also have mice now, and they also have their own quirks, but it's an ongoing development which actually have humanized immune systems. So we can actually make mice now that actually carry, they don't have their own immune system, they have a human immune system. And so that's again another sort of translational advance going forward. But overall, I think we should never stop. And obviously people would need to be willing to contribute and consent to it, but we should never stop studying human spinal cord injury. And in fact, we should do more of it, I think, and hopefully that's something that will come out of tonight, that we'll keep working together, both at the preclinical, sort of at the discovery stage, and also having that backwards and forwards translation.
We've got a couple of other questions. Yeah. Linz, are you happy to use the mic, just so we, just for people up the back in case they can't hear the questions? You good?
Yeah. I've got a couple of questions. One would be regarding to sport and the rehab that we've got going on. With all the research and everything that's happening, like I was old school, treated back in the day and laid up in tongs for a couple of months, and then had my arms getting moved while in traction, trying to feed myself to keep those muscles moving. Is the funding, like all the research, is that getting fed back to the funding organisation, like NDIS, insurance companies, to say that we need the funding for our clients to go out and get the rehab for physio and everybody like that, the EPs, so that we can keep moving, keep our bodies going, so we don't end up with pressure sores and all those sorts of things, because we're finding resistance trying to ask for that funding so that we can go and get that done. Is that getting fed back into, will you guys be doing clinical trials anytime soon and old school treatment?
Yeah, thanks, Lindsay. That's it's a really important point. And it comes down. I could only best describe it as lumpy in terms of the response that you get. It depends a lot on who's managing your case. It seems at this stage that the evidence makes a difference, but people have got to be aware of the evidence and how important it is. It's a funny little story that when Connor was after Connor had his accident, we were looking to get him engaged in sport and exercise and have it funded through his NDIS plan. I had a conversation with a woman with the NDIS planner who was calling me out as the first author on the exercise guidelines for a spinal cord injury in Australia, saying, "Look, I really don't think he needs it." There are some people who get really good packages at the same time, and I think that we're in a period where it's going to. Claire put up on the slide that I thought was great that one of the skills you need is navigating the NDIS, and it's a skill set all by itself, and managing that is really important. And as the scheme matures and as the evidence comes through, then I think it'll become easier. I'd hope.
Excellent, because it takes away a lot of people's depression, medication, bed rest, and all the other stuff. You actually engage in your body to do better and achieve more independence, even though you need more carers to help you achieve your little goals, but it's the end goals in the long range as well.
And you're less likely to head back into hospital as well.
Yeah, less cost in the system.
Yeah, very true.
The other part with clinical trials, are you looking at doing that anytime soon?
Well, that was sort of what I was getting to. I think it'd be great to have something that sat in. We looked at getting a clinical clinician researcher at we got together a grant application, and it was we had good support from our partners, but the grant application was unsuccessful. So we're hoping to go again, and longitudinal individual cases, that precision medicine sort of approach, evaluating that as a process is something I think we're really interested in doing. Yeah.
Great. We've got a couple more minutes of question time. I see some hands that are still wanting to go up. Yeah, hi.
Thanks. And I suppose picking up on that last point about the precision medicine, Mark, hold the microphone because it is sort of a question for you. You highlighted at the end that need for a registry. And so I suppose thinking from your perspective, one, I'd be interested, do we know, are there other registries out there for spinal cord injury patients in any other countries? And if we were to proceed down those lines, you know, from you as an experimental and then Claire, you as a clinician, what would that look like? What would you need to collect? And even Tim, putting you on the spot, what would you as a consumer be happy to be participating in getting that data?
I think that's
big question, sorry.
It's an excellent question. So there's been various forms of registries. So there's a big North American one that has been mined quite significantly by some groups there. I think what is starting to emerge is actually, you know, there's an initiative in the US which is called Track SCI. They are actually starting to collect data and blood samples like that you can do the things that I showed today. And I think that's really important, that we're not just collecting the routine clinical data, but that we actually prepare for the future as to what the emergent technologies are going to allow us to do. And so it's not that hard. I mean, you know, it needs someone like me, someone like Claire, in a way to say, okay, here is the blood. Blood's already collected routinely, so we can collect it, we can bank it, and we've been using that blood over and over again for various purposes, including for what I showed tonight. So I think those are the things that we have to start now. And it will actually allow us, I think, to really stratify and look at each individual patient and say, you know, even like longer term, well, this is where you were, that was the injury at the outset. Now, these were the interventions that you got, whether they are rehab-based interventions or early drug interventions, or you engage in this level of exercise. What did that actually do to that individual? And then by having a prospective registry, you can actually look back at other individuals that didn't have that. And you can even do that, and I guess that's where the field is changing, because patients are relatively few. The thing is that there is a huge variability, and so unless we actually know that we're comparing an individual to the right group of other individuals based on all these characteristics that play into outcomes, I think we're going to have very noisy and very messy data. And so that, I think, is what we have to change. And so I do think we have a real opportunity here to lead. We have all the tools, we have all the expertise, but we would also definitely link in, I think, with all of those international consortia. And it would actually make us part of probably the most exciting treatments and developments along the whole spectrum, whether it's early care or rehab-based, like late interventions.
Do you want to say anything to that?
I mean, in terms of a registry around clinical factors and, I guess, outcomes and community participation, all of those types of things, you know, that data would be really beneficial, because the numbers aren't huge, as you've mentioned, and to have, say, Australia-wide data would be terrific. There has certainly been attempts for that to be organised, but you know, there's more state-based information at the moment. So yeah, certainly trying to incorporate that, and that's been discussed at our kind of Australian and New Zealand organisational level often.
Hi, I have a question if I can. I've actually got cerebral palsy, so I'm a little bit different, but I'm a hybrid. Everybody calls me the paraplegic, quadriplegic hybrid, can't work you out. So I'm part of the CP Alliance who does have that registry, and we do stem cells, and we do a lot of physio and stuff, and we are still fighting too. So we're still fighting the NDIS for, you guessed it, physio. And if you ask for 2 instead of 1 session a week, they go, please go see a doctor. But the thing we're finding with CP and spinal cord injury as well is that it's not just exercise that works, it's actually at a cellular level of stem cells for us. So for some of us, I've been doing physio since I was very young, so I've got a lot of hand movement that I shouldn't have. Thanks, Mum and Dad, that was great. But what we're finding is the more people that stand up and start saying stuff, the more people listen. And in the state of Queensland, I'm the ambassador for the NDIS in Queensland, and the LACs don't know what they're doing. So what happens is Katie runs around and goes, that person can't move that way because they're a C5, C6. So they class me, believe it or not, as CP, SCI, C5, C6. I'm neither, I'm just a hybrid, and they can't work it out. So I think a lot of clinicians are having a lot of trouble working out what we actually need and why we need it, especially if you are not your stock standard case. I'm definitely a test case, and they're still sort of working out, you're 35, but that should be over now. No, it never stops. So if you kind of get a whole group of you together and start yelling and screaming, it actually does work. It just takes a lot of, yes, there's your EBP. The amount of EBP reports I write for people is phenomenal, and I'm a psychologist as well. So I go and do the mental health reports for them, and they're like, oh, it affects their mental health as well. I'm like, yeah, if you don't move for 6 weeks, you're going to have muscle atrophy. And they're like, really? I'm like, yes. Get it back, you lose it again. So a lot of us lose it at 12 days, a lot of us lose it at 24. Half my mates in the spinal cord injury unit are like, Katie, go tell the doctor before I want to kill him. But I think the more noise you make, the better it is. So sometimes it's a case of making noise and going and talking to Parliament and going and talking to doctors and putting your EBP in your NDIS plans with your professionals in tow. That may take time. Yes, it's annoying, but they can't argue with it. So they hate arguing with paperwork. So if you've got the scientific evidence behind it, they can actually use it. Yes, it takes 46 pages and it's annoying, but Melbourne planners are better than Queensland ones. I was actually trained in Melbourne, and they're going, what the hell's going on with Queensland? It's lax. So if you need to review it, just keep writing EBP and reports, guys. They eventually get it through their head, but it takes a while. So do we have anything to do with stem cells? Because I know CP does, but does spinal cord injury as well? Answer that one. I know it's a curly one, but it's possible.
Look, stem cell therapy in spinal cord injury is being investigated, I think, in many parts of the world. Small numbers of people, obviously a lot of complexity around who to focus on, who to study. Is it, someone who's had an injury for a long period of time, or is it someone early on in an injury who may get some natural recovery?
Yeah.
So there's been a number of studies, but all in kind of early stages, and I don't think there's any overwhelming evidence of how to approach stem cells in spinal cord
there's
injury.
I'm just a medical student, but it just seems like everybody's everywhere and we'll do this and we'll do that, and there's no sort of, okay, we'll kind of do this to help this person actually regain their life. It could help, but I think a multidisciplinary approach would maybe work, and getting the doctors on the same page, you guys on the same page, because a lot of doctors, and I speak to a lot of them, they just don't know enough. They just go, I don't know. So I think that multidisciplinary team would be handy, but maybe in the future we could have people that, regain function and stop atrophying at 120 days. I, at 35, only have got 12 days, and I'm doing it since I was basically 2. So it depends on the person, but I think that atrophy phase is really important to try and get those moving. But yeah, it's just a weird sort of thing where they don't talk. But if you make enough noise, things start happening. Thank you.
You sound like you're an absolute warrior and champion of your own journey. I love it. You speak very well, and you are very passionate about your own health.
Yes.
And I think you raise a really good point about being the, what is it? The squeaky wheel gets the grease. Is that the right saying?
Yeah, it's really important.
Well, us as consumers, we have a responsibility to make sure that our voices are heard, and that we play a part in research, in clinical situations, that we have people with not only, and I was talking to this with you, Mark, prior, but not just sharing our lived experience, because lived experience is great, and it's really important to gain that information and perspective of someone who does live with a certain disability. But I think lived expertise is something that people with disabilities should strive for if they want their voices heard in the right environment and to make change in this area. And so, yeah, that's just something that, I know as a peer support officer, I try to encourage a lot of the patients that we talk to make sure that not only do they learn about their own body, their own health and their own journey from here on in as a disabled person, but they make sure that they learn how to articulately express what their needs are and to ask for help. And then when they get that help, to learn what is happening to them, to not just let things happen around them, that they are the drivers of their own journey and their own rehabilitation, and they're the ones who set their goals and their targets. And that's the language that the NDIS, listens to, isn't it? What are your goals? So us as people with disabilities need to learn how to articulately express what our goals are and what our needs and challenges are to be able to be serviced in the right way. So good on you. Good luck. Thank you for your question. I think we're rounding up now, because I know the drinks are up the back and ready to go. There's networking to be had. Just want to say thank you so much, everybody, for coming here this evening. I would like to thank these wonderful people on stage who have given their time, their professionalism. Please give a round of applause for Professor Sean Tweedy, Dr. Claire Panagata, Alan Gillespie and Associate Professor Mark Rutenberg. Come on, give them a bigger round of applause for that. Yes, thank you for taking your time out of your busy schedules. This is the final Health Matters lecture for 2022. So therefore we hope to see everyone here for our Health Matters series next year that will be continuing on. Please join us now for drinks and canapes and an opportunity to mingle and meet, discuss, talk about what was discussed and presented this evening, swap business cards or do whatever you do in that particular way. It's been my absolute honour and privilege to be your MC here this evening. Thank you very much and have a lovely rest of your evening. Thank you.